Okay, this is your lecture on survivors of abuse or neglect. It's coming from your textbook. This is Townsend, chapter 34. How many of you have heard the statement, there's no place like home? There's no place like home. What does that remind you of? There's no place like home. Okay. Well, this is a statement that's familiar to most of us, and home is usually a source of refuge and it's a source for peace for many. Yet, for some children, for some adults and older adults, the home is a dangerous place where family members and intimate partners demonstrate disregard for the rights of others. Family violence is also known as domestic violence, and it's among the most important public health issues that is occurring in the United States today. So abuse and neglect has become an important concept. It's an important topic for the nursing profession. And this is because as nurses, we are going to be in a position to respond to family violence or intimate violence. We're going to be in a position to educate those about abuse and neglect. We'll be able to identify it, hopefully, and to evaluate the patient and treat both the victims and the perpetrators of violence. We'll be able to treat both. You know, there's going to come a time when you are looking for jobs, and it may be that you have had some incidents that have occurred in your life, and maybe you don't want to work around someone that has committed rape or that has murdered someone. I think about the nursing home where my mom is right now. Rumor has it that someone, a drunk driver, was in an accident and killed someone. Now he's in therapy in the area where my mom is. So you think about, do you wonder if those nurses have concerns about taking care of a patient that willfully abused alcohol or abused drugs? Now they are free for the most part, you know, being taken care of, being rehabbed. So as a nurse, it's going to come a time where you may have to decide, and you can tell your supervisor that maybe I'm not the best nurse to take care of this patient today. It's going to be based on your thoughts and feelings, and that is a right that you have. But today we're going to be talking about family violence, interpersonal violence, ways that we can identify, and things that we can do as a nurse to help that patient to cope and hopefully get well. So how would you define abuse or abuse? How would you define abuse? It's maltreatment of one person by another. And so the major types of abuse are going to be things like physical abuse, there is sexual abuse, emotional abuse, neglect, and economic abuse. We fairly are familiar with most of those types of abuse, but what is economic abuse that will occur? Monetary. It may be someone in the family, or it may be a close friend that will use that victim's money for their own needs instead of using it for the patient's needs. So that is a form of economic abuse. The after effects of abuse oftentimes will lead to anxiety, depression, and suicidal ideation that can last a lifetime for patients that are been abused, or if they've been in households where they were neglected. In fact, major depressive disorder and post-traumatic stress disorder, these are two of the most prevalent disorders that come from childhood trauma that many have faced in their life. Abuse will affect all populations equally, and abuse often is cyclic, meaning that in many abusers, they themselves were victims of abuse as children. So they're only repeating what they have been exposed to, what they have learned from their childhood upbringing. Nurses are legally mandated to report suspected or actual cases of child or vulnerable adult abuse, and each state will have their own specific guidelines for reporting these incidents. There's also a time period that each state will have that the abuse or neglect must be reported, and it could be that it needs to be reported immediately, or it can be reported within 24 hours or within 48 hours. But every abused person, once they come to the hospital or healthcare setting, they are considered a crime victim. So we have to remember that and report it, as we are legally bound to. Let's change subjects and talk about bullying. What is bullying? What is bullying? Okay, so it's usually seen with children where they will intentionally repeat harmful things, call names, threaten, or even shun the person. What are some other things that the bully will do? The bullying can be physical, verbal, or emotional in nature. It could be committed by one or more persons against another. And then these acts or words are just repeated over and over again, where it really hurts the victim that's experiencing the bullying. What is cyberbullying? Okay, that's when you are on an electronic device, such as a computer, using different web browsers or websites, and usually they send mean, vulgar, or threatening messages or imaging, and that's open for the whole World Wide Web, to see. They will post sensitive, private information about another person. Sometimes they will even pretend to be someone else in order to make that person look bad. But they are intentionally excluding someone from an online group. So that cyberbullying can be done using the social media, the email, instant messages, any text, web pages, blogs, even chat rooms. You will see cyberbullying occurring. Is bullying harmful? Is it a big deal? Why do you say so? What effects does the bullying have on the victim? What harm could come? They could kill themselves, commit suicide, and that's something we're seeing in the news media a lot. What are other consequences for that victim that's being bullied? They retaliate and can come to a school with weapons. Okay. Something that happens usually is that child that's bullied, their grades may suffer. They may not want to go to school. They may talk to parents about dropping out. Or they may think of getting revenge in a form of fighting back by bringing a weapon to school or even committing suicide. How does bullying affect the bystanders or onlookers? What effect does it have on bystanders? Yeah, because they don't want their reputation smeared. Okay. And then sometimes they may be afraid that the bullying will turn towards them. Okay. And they don't want to be seen as a snitch. You know how young children are. Also, the person that's the onlooker may experience feelings of guilt or helplessness for not standing up to the bully on behalf of their classmate. Are there any harmful consequences for those who participate in bullying? What have studies found? They may become criminals. Okay? That bullying in childhood may be an early sign of development of some violent tendencies. Okay? And one study found that boys identified as bullies in middle school were 4 times as likely as their non-bullying classmates to have 3 or more criminal convictions by the age of 24. All right? We're going to move along with, there are some factors that have been theorized as the cause of violent behavior. So my question to you is, what predisposes individuals to become abusive? What are some things that have occurred? They've been abused themselves. When you look at the biological theories, these physiological and biochemical influences within the brain have been suggested as causing violent, aggressive behaviors. And that is where you look at the amygdala, the limbic, prefrontal cortex, the temporal lobes in the brain. All of these brain structures, when they become dysfunctional or malfunction, they play a role in the development of aggressive behavior. Also, norepinephrine, what comes to your mind when you are frightened or very anxious? The flight or fight reactions occur. And then with low levels of serotonin and increased levels of dopamine release, this is going to play a role in impulsivity and aggressive behaviors. So these are some biological theories that can cause violent behaviors in some. There are other theories. There's various genetic components that's related to aggressive behavior. Researchers have found a warrior gene. Have you ever heard of a warrior gene? It's the MAOA gene. Abnormal versions of this MAOA gene can cause aggressive behaviors. Okay? And then there's organic brain syndromes associated with various cerebral disorders, the traumatic brain injury that you all learned about. All of these disorders, brain tumors, encephalopathy, epilepsy, all of these have been implicated in the predisposition to developing aggressive and violent behaviors. There is a psychological theory. They imply that unmet needs for satisfaction and security causes an undeveloped ego in some. And it's thought that when that person becomes frustrated, then they have that aggression and violence. They display aggression and violence because it helps to supply that person with a dose of power that's going to boost their self-image. So that's the psychodynamic theories. Now the learning theories is just like someone said earlier. The person that's violent is violent because they've learned that from somewhere. They've learned it from a parent. They've learned it from a role model. But it will cause that child to imitate abusive behaviors that the parents displayed. Okay. Also, if abused during childhood, or if that child has witnessed some domestic violence, or maybe they are habitually watching movies or violence on TV, this child is more likely to manifest aggression as an adult. You just think about the games that you played when you were young. Now, some of you are still fairly young. What kind of games did you play? Doctor, do you remember the game that you would set on a table and you would have this little device to go in and take care of the little patient that was late? Okay, what was it called?
Operation.
Operation. Okay, who played that game? All right. Now, who played the game where you are shooting? You're using the computer games and shooting. All right. Well, who played the games where you're racing? You just drag racing with the games. Okay. So which one of those do you think may be a little assertive or a little aggressive when it comes to playing games? Okay. So you can see that these theories, they do have something. Okay. Red Rover, Red Rover. Okay. So a lot of these behaviors could come from malfunctioning of the brain. It could be a chemical imbalance that's occurring in the brain. It could be some type of psychologic, dynamic problem going on with that person, or it could be something that is learned by that individual. What does sociocultural theorists say? They believe that aggressive behavior is influenced by our own culture. So exposure to violence in a community and in the family have all been linked to increases in anxiety for those children that grow up into adulthood. What questions do you have about what abuse or neglect is and some of the causes? Well, let's talk about the application of the nursing process. As a nurse, you're going to encounter victims of violence in every healthcare setting that you go in, not just the psych setting. So all patients should be screened in some way for possible abuse. And all assessments should include questions that's going to elicit history of sexual abuse, maybe questions that elicit information about family violence or drug use or abuse. Have you seen that on your psychosocial intake at the psychiatric facilities? Have you seen any of this type screening done in the just regular healthcare setting? Okay, so it all starts with the patient's general appearance. That's going to be the clue. Their posture and also their mental status. And so what you're going to be assessing for is for any clues that would make you think that this patient has been physically violated, sexually violated, if they mention anything about having a stalker, or if there's some psychological aggression being displayed. Okay? Now your textbook on page 767 and 768, go there and tell us how does it describe the victim or the profile of a victim. How does your textbook describe the profile of a victim? Mostly on 768. What are some characteristics of the victim? They're mostly women. And I think your book talked about just a small percentage of men. About 24% victims are men. They're going to have low self-esteem. Okay. Mm-hmm. Okay, so they have some learned helplessness from growing up in abusive homes. As she said, they have an inadequate support system. Many of you have said low self-esteem, accept blame for the batterer's actions. And it is, the largest percent is women, and they come from all types of background, age, racial, religious, cultural, educational, and socioeconomic groups. Okay? Now, how does the textbook describe the profile of the victimizer, the perpetrator that's causing the violence? Okay, again, they have low self-esteem. They're jealous-hearted nature. They view their spouse as a personal possession. They have severe stress reactions. Okay. Okay. Now, what would cause a victimizer to develop characteristics or traits such as those? Because they've been through it. Again, they lived through it themselves, that learned behavior. Any other thoughts about that question? Okay. They have some personality disorders, the narcissistic. Okay. Watched it in their home. That's all they know. So is that victimizer going to walk up and hug their spouse or their intimate partner if they've never seen it done in the home? Okay. You know what a lot of men do for their loved ones. Will you see behavior such as that? If they've never seen that in the home, all they've seen is violence, abuse. So that's what they're going to imitate. Now let's talk about intimate partner violence. Let's talk about the cycle of violence. This cycle consists of 3 stages: the tension building stage, the acute battering stage, and the honeymoon stage. Which phase begins with minor incidents such as pushing, shoving, and verbal abuse? Which one? It's the tension building. Exactly. Which phase occurs when the tension peaks, and sometimes the victim may provoke the incident to remove the tension and get on to that honeymoon phase. That's phase 2. And then which phase is when the abuser usually demonstrates kindness and loving behaviors? That's in 3. And so this is a vicious cycle that goes round and round and round. Unfortunately, without intervention, the cycle will continue to repeat itself, and over time, the periods of calmness and safety become briefer, and the periods of anger and fear are going to be more intense and sometimes lead to violence, homicidal type events occurring. Okay? So according to your textbook on page 769, why does the battered woman or man stay in that environment? Why do they stay? Okay, fear of retaliation. This is found in your book on page 769. Okay, they've been told that you don't know anything, you can't work, and so they begin to believe that. So they feel like they're better off if they stay financially, better off financially if they stay in the relationship. Their children, that's my kid's father. They keep thinking that it's going to get better. And sometimes it does, but then that cycle will eventually repeat itself. Lack of support. Okay, we don't believe in divorces. No one in our family has ever had a divorce. You can't divorce him. What are you going to do if you divorce him? So a lot of times it's the information that the abuser has been telling you that you begin to believe, but then also family members can add on and gaslight you and think that it's true, that you're not able to support or take care of yourself. So have you ever thought, why would a victim stay in a situation like that? They are just paralyzed. They're paralyzed into taking no action. And this is due to a combination of physical threats and then the sense of just feeling powerless. Okay? All right. So it is important for you to recognize that when a victim leaves an abusive relationship, they are at a 75% greater risk of being killed by their partner. And they remained at a 75% increased risk of violence after being separated from that person at least 2 years. So it's not enough to just walk away, but if they find you, you're still going to be affected. Let's talk about child abuse. Child maltreatment typically involves physical, it could be emotional injury, physical or emotional neglect, or it could be from sexual acts. According to page 770, what are indicators of physical abuse in children? What will you see in that child that's been physically abused? Yeah, the injuries, the broken bones, injuries in various stages of healing. Maybe they got a dark hematoma, and then they got some yellow-blue. They got various stages of the bruises or contusions healing. Are they frightened of their parents? Okay, your resource said they seem frightened of parents. They seem frightened of going home. They shrink at the approach of adults. That child may abuse animals or pets. Again, that learned behavior, imitating that behavior. Okay, those of you that went to the Alliance Adolescent, did you see any reading in the charts about abuse of animals? Y'all didn't? Okay. Good. Usually you will see, especially in conduct disorder, especially, you will see where they will set things on fire, that they will kill pets, abuse pets. But these are signs and symptoms of child abuse. Here are some other symptoms. A lot of times when you are talking about the abuse, the child may say one thing. The parents may have two different appearances about what really occurred or what really was said. Their stories don't match. You may see that the parent uses harsh discipline with the child. And we've talked about the history of abusing pets. Okay? Now, what are some indicators of child emotional abuse? Low self-esteem. They don't have the ability to develop emotional bonds with others. They may appear depressed and suicidal. What would be an example of emotional abuse for a child? saying you're stupid, you're crazy, or saying things about the parent and you're just like the parent? What were you saying? Mhm. Right. Okay. Here are some other examples of emotional abuse where that parent is constantly blaming or belittling or berating the child. They're unconcerned about the child and refuse to help them with their problems. What are some indicators of child neglect? Yeah. They're not at school, poor hygiene, they lack medical or dental care or hygiene care. Maybe their clothes are not clean. They may beg or steal money from school, or they may simply state no one is at home to provide care. In this generation, do you think we have the latchkey child as much as we did in the 90s, early 2000s? Y'all know what a latchkey child is? Always at home. Okay. Our next slide talks about the parent or caregiver appearing indifferent to the child. What's an example of being indifferent? Mm-hmm. Doesn't matter. Whatever you want to do. Mm-hmm. Say again. Okay. All right. And then the child may appear apathetic or depressed, may behave irrationally, or may begin to misuse alcohol and drugs. Okay? And this is why a lot of children will turn to the streets. What do I mean about turn to the streets? Turn to those out in the street that pay attention to them, that show them some love, that give them good money. They will do that. Okay. Lastly, what are indicators of child sexual abuse? And this is found in your textbook on page 771. How would you know that a child may have been sexually penetrated or sexually abused? Okay, bedwetting again, nightmares. They don't want to go to school. They don't want to go to the bathroom and use the bathroom. And should a 4-year-old know about kissing or having any parts of a sexual relationship? They should not. And when you find one that does, it's a great possibility that they've been sexually abused. The child may have difficulty sitting. They may become pregnant. They may run away. They may attach quickly to strangers or new adults. Why do they do that? They feel safer, you think? Okay. What do the others say? It may be that they're introduced to multiple people a good bit of time, especially when you think about sex trafficking occurring. Here are some other indicators of sexual abuse. They're secretive, isolated, engages in unwanted touching of another child, tries to be child's friend instead of the adult role. There's some others there on the slide. The perpetrator may make up excuses to be alone with that child, give gifts to the child. Okay. So let's talk about what are characteristics of adults who abuse or neglect their children. What are some of their characteristics? Okay. So they probably were victims of childhood abuse themselves. As she said, they may have substance use disorders. They may be the parent that withholds care or basic needs from the child. Any other thing that piques your interest on characteristic on an adult who would abuse or neglect their children? Yes, they do expect their child to be perfect. And when the child is not perfect, then they are usually disciplined in some way. Your textbook also included incestuous relationship on page 772. In most cases, who is it that's being involved in a incestuous relationship? Who in the family? The father and the daughter. And because of communication between the parents are ineffective, then this problem continues, and they don't communicate to try to correct what's occurring. What type personality is the father that's abusing his child? Dominating, impulsive, physically abusive. And what about the mother? What type characteristics does she have? Passive and submissive. Okay. If incest has been reported with one member of the family, then it should be suspected with all of the other family members, whether they're children, especially if they are girls, but whether they're boys or girls, you would suspect it. Okay. Your next question is dealing with the adult survivor of incest. What is the result of someone who has survived childhood sexual abuse or incest? Mm-hmm. Mm-hmm. Because the family secret has been revealed. And many are not proud of it, but they don't want to hear the truth about the family secret. So how does this childhood sexual abuse disrupt the development of the person that survived it? You know, are they going to be loving and caring towards a spouse? Would it be difficult for them to do that? Okay. They may have an aversion to sexual activity. They may have a change in their libido. In males, they may have developed some erectile dysfunction. And usually the survivor of incest and childhood sexual abuse, they're going to be the ones that we see a lot of times in the psychiatric settings, dealing with depression, anxiety, substance abuse, eating disorders, suicidal behaviors, unstable relationships with personality disorders, and they're going to have an increased risk of a history of child maltreatment, meaning that learned behavior will come into play, where they will begin to mistreat their children. What about women? Your textbook went well into depth talking about women who were abused as children. what do they tend to enter as adults? Abusive relationships, and they're taken advantage of. Okay. The sexual violence that occurs, you all are familiar that it is any sexual activity when consent is not obtained or given. A lot of people used to use the term date rape. Now it's called acquaintance rape. The date rape was centered around Rohypnol or any medication that would cause amnesia, where the woman was not aware, or even men, children now, that were not aware of what was going on and don't remember the rape. There's also marital rape and also statutory rape. It's any type of sexual activity where consent is not given. So the profile of the victimizer, the perpetrator, what is their profile? Okay, that's right. Now the victim, who are the victims of rape? Okay, so it was someone they knew, someone that had been watching and monitoring their whereabouts, and it occurred in their own neighborhoods or somewhere nearby. So it was definitely someone they knew. Okay. Next slide deals with the rape trauma syndrome. This is found in your book on page 775. Whenever a rape survivor comes to the emergency room, you know, they come usually shortly after that crime has occurred. And so there is a rape trauma syndrome that's been identified, and it identifies 2 emotional patterns of response that will occur within hours after a rape. And the first one is the rape trauma syndrome. In the express response pattern, the survivor expresses feeling of fear, they're angry, they're anxious, they're crying, sobbing, they're just really in shock about what has occurred. The second emotion that they will show is a controlled response pattern, where the feelings may be masked or hidden, and they may come across as being calm, composed, or subdued when they're talking about the rape. And that's what's described as the rape trauma syndrome. Now, when you're looking at sexual violence, your nursing diagnoses or the priorities of your care is going to be rape trauma syndrome, powerlessness, and risk for delayed child development. Some of the outcomes, and this is specifically from your textbook, go over that slide, but what you're looking for in the long run as your outcome is that person that has been physically violated or sexually violated, you want them to be reassured of their safety. And you also want them to have decrease in their panic, anxiety. You want to be sure that the trauma-informed care has been incorporated and started. And then any wounds that they may have, any injuries, those need to be cared for. And then the emotional needs also need to be cared for. Some other outcomes of evaluation that you want to see at the end before this person has been discharged from the hospital, but also long term, if they go through some group counseling or peer support groups, you want that patient to eventually start to trust other people. You want them to have some support systems in place, and you're going to do some long-term evaluation, because if this woman was assaulted in January, do you think this is over for her? Every time she lays down, every time she walks into a darkened room, every time she unlocks her door and walks into her home, whatever the scenario was, this is going to follow that woman lifelong. I don't think we've talked about that. Now let's get to this trauma-informed care. This is something that's in place to help victims integrate the trauma into their lives, sort of like the post-traumatic syndrome. They need to know that this did occur to you. It's over now. You're safe now. And we have to continue on with life. Okay? So the trauma-informed care shifts the focus from what's wrong with you to what happened to you. And it's going to help avoid any re-traumatization to occur. Crisis intervention. This is over on page 781. You're going to do an initial interview with the patient, and then there's going to be a follow-up. And when they're going through these crisis intervention, it's trying to get that woman or that victim back to being whole again, to being able to sense that they have some control, and for them to start to making decisions again. So it helps that person to draw on previous coping skills and strategies to try to regain control over their life again. And again, this could be through peer support group or group therapy. Now, the last thing we want to talk about is the safe house or shelter. This is something that we need to give them information on, because most of the shelters are going to provide individual and group therapy, and they offer a whole lot of resources to the patient. It's going to provide them with physical safety. It can get them in touch with someone to help them build on some vocational training. It's going to help them with financial resources that are available that they can apply for. So getting them in touch with a safe house or shelter is a priority nursing intervention. The family therapy, again, is something that's always going to be recommended, because studies show that the more family uses the democratic means of conflict resolution, the less likely they are to engage in physical violence. All right. Now, right now, I want you to turn in your textbooks to page 777. We're going to be looking at the nursing care plan for taking care of anyone that has been abused or had some type of neglect. So when you look at sexual assault, we're going to look at the nursing interventions and also the rationales. So it's going to be important to communicate to that individual that's been sexually assaulted that they are safe here at the hospital, at the clinic, wherever they are safe. You can express apathy. that you are sorry that it happened. You're glad that they survived. You let them know that it's not their fault, that no one deserves to be treated this way, and you did the best that you could. Why are we intervening in such a manner to the victim of sexual assault? Why would we intervene in that manner? Okay. So you can decrease some of the anxiety. We want to start off very first in trying to decrease some of that self-blame, that self-worth. They may not feel worthy. And we want the lady to be assured, or the child, or whomever. We want them to be assured that they are safe. Anytime that the patient may ask a question about, will I be safe here if the perpetrator comes for a visit, we need to ask more questions. You know, why would we need to intervene on that quickly? If they're asking you a question, will the perpetrator, if they come visit me, will I be safe? What happens when the gangs are shooting it up outside in the community? What do they usually do to the hospital? They may lock it down. So they may not lock it down for the perpetrator, but they would certainly be looking for them, because they don't need to come in and disturb that woman or continue that violence towards the woman. The next thing you're going to do is complete a physical assessment. You're going to explain every assessment procedure that will be conducted and why it's being conducted. You're going to ensure that data collection is collected in a caring, non-judgmental manner. You're going to engage the services of a sexual assault nurse examiner, and that's where the meaning of SANE come from, S-A-N-E. That's the sexual assault nurse examiner. And that same nurse is going to facilitate collecting evidence off the patient's body, and the same nurse will be an advocate for that patient. So you're not going to let the patient shower. You're not going to throw anything away. All of their clothes will be collected by the same nurse, and they will be put away safely. Has anybody ever been in the emergency room and seen the same nurse come in and provide care? Well, it's just like it is on TV, where they have a little bag, they have a comb, they're combing pubic hairs off the woman to make sure that they're able to recognize what is her own and what is someone else's. It's very interesting to watch them gather evidence. So once you complete that physical assessment, you're concerned about gaining that forensic evidence. You're going to take care of the victim's injuries. You're going to be taking care of that patient's needs. You're also going to ensure that the patient has adequate privacy, and you try to have as few people as possible providing that immediate care or collecting any immediate evidence. Why does it need to be few people around the victim? Okay. You want to decrease anxiety again. You don't want them to feel vulnerable again by having lots of people and more talking and more noises in the room. Something else that you're going to do is encourage the patient to give an account of the assault, and you're going to listen non-judgmentally. You're going to listen, but you're not going to probe. Okay? And then you're going to discuss whom to call for support or assistance and provide information about referrals for aftercare. Now, all of this information that you are providing that patient, you're going to verbally say it, but the best thing that the nurse is going to do is put it in writing for this patient. Because when that patient needs that information and a crisis situation has developed where she's fearing for her life, is she's going to remember what you said? No. So you need to put it in writing and tell her to keep it in a safe place so that she can have that. And so some of the things that you're going to give her is like a telephone number for the nearest shelter. Keep a cell phone battery charged up and within your reach. Create a code word to share with children as a signal to leave. That reminds me of our code word last week. What was it? Red, but the other group had another one. Check. That was very funny. Check. All right. But getting back to what you're going to put in writing, you're also going to keep some money hidden to take along with you. So you're going to make sure that any victim of domestic violence or sexual assault by their mate or partner, you're going to make sure that they have an emergency plan for escape. Other things that you do for sexual assault is discuss options for support and assistance. We've talked about providing information of an abuse shelter, because that shelter is going to have everything that that patient needs. It's going to be shelter, food, financial means, spiritual means, vocational, and emotional support for them. So be sure that you give them a shelter. You want to give them the information for shelter. Do you all need a break? Okay, we'll take our first break. Okay, let's turn to page 778, and we're going to talk about the care plan for survivors of abuse when they are battered women in domestic violence issues. So what we're going to do is, in collaboration with that physician, we're going to ensure that all physical wounds, any fractures, any burns, that they receive immediate attention, and we're going to take photographs if the patient permits. Why are we doing that? Legal documentation, and those photographs may be called as evidence if charges are filed. We're also going to take that patient to a private area to do an interview. We never want to talk to that patient in front of the perpetrator or the victimizer. We want to make something up. If they need an x-ray but not really, we're going to get them out of bed, undress them, put them a gown on so we can see the body, put them in a wheelchair, and out of the room we go. We may just go to the bathroom, but we're going to get that woman away from the victimizer. We're going to talk with her one-on-one so that hopefully she will feel safe sharing her thoughts and feelings. If the patient has come along or with her children, again, we're going to assure her that she's safe and encourage her to talk about the battering incident, and we're going to ask questions about what happened, whether the abuser is taking drugs, whether the woman has a safe place to go, and whether she's interested in pressing charges. Okay? So we're going to ask about those things, but what's the priority? Safety and taking care of the wounds. All right? Ensure that rescue efforts are not attempted by the nurse. Ensure that rescue efforts are not attempted by the nurse. Okay? How could we be, in effect, trying to rescue the patient? You know, that happened to me before, and this is what I did, and this is what you need to do. We can't go in with that type of stance about it. But we have to play it by the book, because remember, this is going to court, and we want our documentation to match. It's not about us, it's about the patient. So we're not going to try to rescue the patient. But we are going to stress to the patient the importance of safety We're going to talk about the resources, the hotlines, the community groups for women who's been abused. We're going to, again, give her numbers and information, written information about the shelters and all that she needs to do to help keep herself safe in case a crisis occurs. She can't think clearly. We're going to be talking to them about that. And then after we had a discussion about these resources, the woman has to choose for herself. We can't make that decision for her. And if her decision is to return to the marriage or return to the home, then we have to respect that choice that she's made. Okay? And so again, if that patient asks if they're going to be safe, if their partner comes to visit, then we should immediately follow up on that question. Find out why she's saying that. That person could already be there in the hospital. But again, we're going to complete a physical assessment and take care of the woman's injuries. What is different about treating patients that come to the emergency room versus treating them that come in because they have been assaulted? What's different? What's the difference between anybody that comes to the emergency room to be seen and versus the patient that comes in because of being assaulted? Mm-hmm. Okay. And even though we're taking care of anybody's physical ailments that come in, along with taking care of their wounds and injuries, we're also providing that support that they need about you are safe here. Trying to be confident ourselves in the way that we approach the patient. All right. The last thing we're going to talk about is child abuse. It's on page 779. This could also go for that elder abuse. You ask that older adult if they feel safe at home. If they come in battered, ask them, do they feel safe at home? Because the child may be sent back home with the parent, but we don't necessarily want to send the older adult back home into a unsafe environment. And you don't want to send a child either, but what can you do if the parent says, I'm taking my daughter home or my son home? Okay, so what you're going to do is perform a complete physical assessment of that child. And again, you need to look at that whole body whenever you suspect abuse, because where is the abuser going to leave marks? Hidden under the clothes, where you probably wouldn't think of looking at if they came to the emergency room. So you want to take particular note of any bruises, any various stages of healing, any laceration, any patient complaints of pain in specific areas. We don't want to overlook or discount the possibility of sexual abuse, but we want to assess for any nonverbal signs of abuse, aggressive conduct, excessive fears, extreme hyperactivity, apathy, withdrawal, and age-inappropriate behaviors. As we were talking before, a 5-year-old should know that you can be touched on the breast, or any of the other things about sex. They should not know that. And if they do, then we need to investigate further. Why does this child know this information? The second thing you're going to do is conduct an in-depth interview with the parent or adult who accompanies the child. And if the injury is being reported as an accident, is that explanation reasonable? You have to think about that. Is the injury consistent with the explanation that the family is giving? Is the injury consistent with the child's developmental capabilities? So you have to critically think about that during the in-depth interview. And then With children, you all know when you learn about assessing children, sometimes we have to play with them. We have to gain their trust. We have to give them our stethoscope and let them hold it and teach them how to use it, all kinds of things like that. Well, the same thing with when they come in with child abuse. We have to use games or play therapy to gain that child's trust. And we use these techniques to assist in describing that child's side of the story. They will often draw. You all watch Criminal Minds or Law and Order, all of that, where they're using art to express what's bothering them. So in order to get that child to talk with us, we've got to develop a trusting relationship with the child, and we have to listen to the child in a non-judgmental manner. Now, a lot of times they will not let us interview a child. They are in the accompaniment of their parents, so that interview has to take place with the parents there. And if there's substantial evidence that proves that the child is abused, then that's when the police will take over and get that child's side of the story. Okay. Now, what questions or comments do you have about the abuse